He bought me a box of soups.
Oh, it was quite funny. Well, we had to get you a box of soup.
And I bought you a beer.
Fasting day. Meow!
Yeah.
Meow! This is Kitty Cat. She works currently as an ICU in a Toronto University hospital, not the University Health Network. And you do mostly ICU trauma, and half the time you run around the hospital responding to patients who are crashing, so you can try and fix them or take them to the ICU.
Yes.
And more than half your shifts in the ICU you're in charge, I would imagine now.
Yes.
Yes. So Kitty's got a lot of background. She's been nursing now since
1989.
1989. Hard to believe. And she's going to talk about her lived experience in December of 2020, having gone through a minor wave of COVID in Toronto back in April and March. And currently we're going through a bigger wave that's still unraveling here in November, December of 2020. So if you have any questions directly for Kitty, put them in the comments below. And for everybody out there who's a frontline worker, you have my admiration. I hide in my office as much as I can. I'm actually a hospital administrator, but I do actually interface with COVID patients and stuff like that, though I try not to. So Kitty, what is the one thing you would like anybody out there to know about what you've been going through if they're not going to work in healthcare? A tough question, eh?
Yeah. Well, that's a tough one. I'd have to say, if you were asking about what it is like being in healthcare at the moment, I'd say that COVID and this kind of pandemic that we're going through makes our work considerably harder.
Hard.
It makes it considerably more uncomfortable. It makes it considerably more frightening. And it makes our lives more difficult, even with our coworkers. There's a lot more stress. There's a lot more physical discomfort. There's a changing environment, so our rules are changing often and all the time. Whether it's rules regarding visitors, whether it's rules regarding how we're supposed to treat people that we have no history on and we don't know whether they might be positive or not. What we're supposed to do with all sorts of variables in terms of the circumstances that patients arrive with us, because we are mostly trauma. They may not have been conscious to answer questions. We may not know who they are. So we have no idea whether they may have COVID as well as a car accident or not. Mm-hmm. So it's
harder.
It's harder.
So a lot of people out there, not a lot of people out there thankfully, but there's some immature people out there that actually claim that there isn't really a pandemic and that people like you are actually going to work and looking after a lot of empty beds and playing around and making TikTok videos.
No.
How true is that?
No, there was a time in the beginning of this, like let's say last March or last April, when our hospitals had shut down
everything.
Surgeries. All departments that could had retracted or closed. We had no visitors coming in. We had fewer people coming in with things like heart attacks and things, maybe just because they stayed home, I don't know. But we had less of our normal volume, and yet we're not overrun with COVID. So I looked at that time as a good adjustment time, because if you have never tried to look after someone who has an infectious disease, you don't know that it actually takes practice to put on your gear, go in a room, deliver care safely, and come out of the room and take off your contaminated equipment safely. And that takes repetitive practice. And we had enough time without being overrun to get used to that and to go through a phase where we had extra nurses to help check people that they were going in the room and they were wearing the right stuff.
So that was about 6 weeks. That was about 6 weeks. Yeah.
So it's not that we weren't doing anything. It's that it gave us a little bit of time to actually
we did have an entire... We created 3 ICUs for COVID back then, which was totally ridiculous. But anyway, I wasn't involved in that. One of the ICUs was half of the CICU, the cardiac unit, and they had literally nobody for about a 5-week period. And that was an absolute disgrace for various reasons. But there was have been a time where that unit was actually empty for 5 weeks with staffed waiting for people to come. And there was no need to redeploy them because everybody was fairly well staffed, and there was no need to admit there because we didn't have anybody that made criteria. That's not the case anymore. What we have now is pretty much we have 1 or 2 beds in the ICU program a shift, the entire program, including COVID ICU. And we generally have patients in recovery and emerge pretty much every shift who need to be in an ICU, but we have no physical capacity to put them in. So I think it's a bit of a cheek to turn around and look at 2 or 3 quite immature videos, and admittedly some hospitals put out, of dancing happy staff in empty COVID units and claim that the COVID wasn't an issue. There's also one of the things people claim all the time is the emerge departments are empty. That's certainly not true in my hospital.
No. Now, because of the large amount of community spread right now, I have heard a few people say that their emerges are starting to tack a little lighter than average.
We're not.
More COVID, but less other patients. And that is because people are afraid to go to emerge. So we are not seeing that yet. In fact, after the first...
We're higher, actually. Our emerge is significantly higher.
Yeah. After the first wave, when it was summer and numbers were lower and things were looking pretty good here, we got whacked with a terrible trauma season. So we have been running
suicides, violence, car accidents, people driving faster than
pedestrians, hit, suicide, all sorts of
The trauma
things.
toll's been terrible.
So the trauma population, I mean, at one point, our whole unit was full of male traumas. That's not normal because we offer life support, so we often have sick cancer patients, anybody who needs a ventilator. We often have, at least 30 or 40% of patients that are not traumas. There's some other medical problem that are ventilated. So to have it, it's been a brutal trauma season.
It's still going on.
And so we aren't running with empty beds at all. I mean, occasionally on a shift I come in and there are empty beds and we fill them, and that's our norm. We don't usually have a lot of staff.
I would say most of the time you're actually running short staffed, aren't you? By 1 or 2, sometimes more.
The staffing problem is actually getting worse. I think because of the long, protracted course, people are getting more tired. People who were working a lot more overtime are less willing to.
People are getting infected.
Winter's coming. We've had some staff outbreaks. People are just not as willing. It's dark, it's depressing. They don't have their usual stress relievers. So we're starting to see some wear and tear on staff.
How effective do you think the hospital that you're at is being in communicating what's going on to you lot?
They're not particularly being that effective now. Now, whether it's because they don't want to make people panic, I don't know. But we've had staff outbreaks that we only learn about through the grapevine, and that's not the most reliable source. So it would certainly be better to know. We don't have to name names of who has it, but they're not doing sufficient contact tracing amongst staff, in my opinion. And it would be good if they told us how many
times have you been told to be swabbed?
Just once.
Okay. How many times have you been swabbed?
Just twice.
Right. So, as I keep pointing out to people, I work full-time in the hospital on nights, and I go to multiple areas of the hospital, and I have been asked to be swabbed, not at all. The hospital has decided not at all to swab me. Even the C5 outbreak, which was a trauma floor, I was on that floor quite heavily the night before they decided it was an outbreak, because obviously we're moving people into single rooms who've got symptoms. Nobody ever swabbed me, nobody ever told me to be swabbed. So it's like this invisible area. And certainly that happened with the CVICU outbreak, that we only found out about it about a week after. That was a nurse who's infected by her child at school, go figure. And she infected, we were told, and we believe 4 of the nurses during a meal break. But there's nowhere to go on your own. We already have nurses eating food in the corridors, right, on 13-hour shifts. There's no planning been done to allow people to go and get some safe space to eat and relax. So all of those things are lacking, so go figure if nurses get together and eat. because they're human beings.
Well, and
but
you're
we
sitting
weren't
in your
told
break room,
about that
so-
outbreak. I mean, I know for a fact I was in that unit during the outbreak, and nobody tells you. They say, well, if you wear a mask, you're fine. So that's a default. Whereas we know people can wear a mask and we can get infected.
Yeah, so it's a little bit. It breeds a sort of atmosphere of not that much trust.
Right. So one of the other things is you've had a lot of retirements,
Oh yes, a lot of retirements.
like significant, right?
Yes, I think if anyone was close to the edge, they
bailed.
They bailed. A few people. One of my friends moved out east to the East Coast to be closer to a family.
It's also safer in the east coast of Canada.
You know, someone had been out east and her dog was out east and they wouldn't let her bring it home, so she actually wound up moving back. Various things. We've had. We've been hiring as much as we can hire at the same time, and we've been getting staff reallocated from different places. So if they like the ICU, they are taking training coming to the ICU. But it's been a net loss right at the moment.
A significant hit, actually.
Because we lose our senior nurses, and they're the ones with the most experience.
Speaking of which, we hopefully will be 3 to 6 months away from retirement. Maybe?
6 to 9, I
6
think
to
is more
9.
likely.
She's going to keep me working there until I die, I think. One of the other things I think we should talk about is the protocols in place if people become positive at work. So you're often in charge of the major level 3 ventilated ICU. Do you specifically know what to do if, say, one of your staff, say Tina, comes up to you at 3 in the morning and says, I feel really sick, I just took my temperature and it's 38.2. Do you actually know what to do?
Well, I would probably put her in an N95 mask and send her home.
Okay.
Immediately.
Who would you inform?
I would inform all of my management level and OHS. And IP and C, I guess, but they wouldn't be
They
in
wouldn't
it.
answer in that's another issue.
I would...
Which will be a separate video.
Yeah, I mean, I couldn't send anyone who'd been in contact with her that night at home because I would be
Would you put the
jeopardizing-
patient she's been nursing into as a PUI if they weren't?
Well, our protocol is that you do wear a mask and you do wear a face shield and you do wear gloves with all of the patients.
Do
that you
people
look
always
after.
do that?
People always wear a mask. People always wear gloves. People usually wear a face mask. I mean, a face shield on top. I wouldn't say it's 100%. I mean, you got to think about it. The face shield and the face mask, if I'm sitting at my desk charting, or I'm doing non-patient care things, is not a comfortable thing to wear. So people tend to take them off and throw them out. And then if your patient alarms, are you going to put something like that back on every second? I'm not talking about an isolated patient. I'm talking about a patient that's...
No, I'm not talking about isolated. They're
So-
easier in a way.
Are you going to go through that and throw that out? And we all feel a certain weight about the garbage that we're creating. Are you going to wear this thing the whole shift? Are you going to take it off and put it on? You can't reuse your face shield safely.
Although initially they said you could.
Well, you can't. You
No,
can
I know.
keep it
They
on.
No, they said initially that you could wipe them down and reuse them.
Yeah, no, we don't reuse them. So
People are making stuff up.
So I would say that compliance is probably 80% with face shields. We do have some that have a shield integrated in a mask, so people who wear those can keep them on longer without feeling like you're underwater.
Right. But you don't have written protocols for any of this. You don't have people haven't sat down in the last 9 months and written out what you do.
We have instruction guidelines
Do you?
to what to wear when.
No, I mean for informing people if somebody gets sick.
If Tina was sick. In mid-shift. Yeah, I think that...
Does she go into quarantine? Yes.
Yes, she goes into quarantine.
Does a patient do the people she's covered for break? Like, where does it end? Right?
Well, that's where
How significant is it?
OHS would have to start. I am not responsible for starting that cascade.
Good luck getting them at 3 in the morning. That's all I can say. It's been an absolute disaster.
I would do the best
that you think you can do.
that I can at night. So you can institute... have the nurses that feel that they were exposed to Tina at some point wear N95 masks. Have them be aware.
Why are you
that,
guys wearing N95 masks now routinely?
Well, I know you think it's appalling, and
I'm biased on this.
we wear N95s when have a COVID patient and we're doing what we consider to be high risk interventions, but we are not necessarily wearing one all the time with them. They're We're wearing
surgical
masks and
for COVID
shields
positive patients.
and gowns and gloves, and a lot of people have their hair covered, which is not mandatory. And we're doing that because a lot of the time our patients are ventilated, and it's a closed circuit system. So the air they're breathing in and the air they're breathing out is going through the ventilator and is vented not to us.
Where to?
Outside.
Don't hang around near hospitals. Seriously.
So, I know there were supply issues. There probably still are supply issues. There probably are cost issues. There probably are a whole lot of issues. But one that I would say most of my nurses would say at this point, after all these months of it, is, do you know what it's like to wear an N95 mask for 12 hours?
I do, because I do.
You don't. You sit in your office by yourself and you don't.
4 to 5 hours I often wear one for.
Yeah, try 12. It's really not a good thing.
Alright. However, all of that set aside, have you seen any other supply issues in the last few months?
Yes, we have had backlogs or...
missing.
Well, we have had notice that vendors can't supply various things, from suction tubing to drugs. We've had to come up with protocols, say we don't have any IV labetalol, IV hydralazine, IV vasopressin.
They're all medications in huge demand right now, because people who have COVID-19 on ventilator who get organ failure are put on those drugs to try and raise or lower their blood pressure. So globally, we're running out of them.
Yeah, so we, so there's been supply chain interruptions, and usually they're short term. Usually there's something of an alternative that we can use. So we might switch to oral drugs if we're running out of IV supplies. We might get smaller catheters that aren't as good, but that's what we can get for suctioning.
They had a significant problem with that this week. I don't know if you knew that.
The small catheters for suctioning? What was that?
I think it was CVD. I think they lost the patient.
Because it
got stuck in there. That's what the small catheters do, right? You know when you put them in, they get stuck. Yeah, I think it was CV. Yeah. Again, it's been hushed.
You could always open suction.
They didn't know what they were doing. That's what they said. You need to do open suction, but that's aerosol generated.
It is. Now that is an aerosol generated.
But it was a problem during the suctioning, and it got stuck. Like they couldn't get it out.
Or just ET?
It was a trach. It was a trach vent. But I've seen that myself with small ball catheter suction. That's not unknown, but apparently they did this without realising that could happen. But again, the people making the decisions don't have background, don't have years of experience, haven't dealt with these issues before, and are literally making stuff up, which they're doing their best job at. But it's kind of the gaps are really getting big. Like in the management team, we are shedding people because people are just quitting. People are voting with their feet.
Yeah, no, it's if you get worn out, if you're close to escaping, you might want to escape now.
So what about the vaccine? You are probably going to be one of the first people in Canada to get it.
I think they're going to do long-term care health workers first.
And people like yourself in ICU, because we're running out of ICU nurses, right? We are running out of you guys, so there is, and we're getting significant outbreaks amongst ICU nurses now, so I think you will be probably first in the queue. They will give it to long-term care workers and ICU workers before they give it to anybody else. But what do you think about having the vaccine?
I will have it.
Right. And I think that's substantially, I've got some reservations about it, but if it's offered, I'm taking it. The chances of having an adverse reaction to a vaccine are actually tiny compared to the adverse reactions of getting COVID-19.
I think the only way for us to move away from the situation that we're in now is for most of us to get vaccinated.
Otherwise this is going to go on.
Will there be some side effects? There always are some side effects, but societally it would be a lot less side effects from the vaccine than there is from COVID.
Well, there wasn't for swine flu, but hopefully they've given enough people this at this point. It's pretty obvious.
Well, we're not even first in the queue.
No, Canada's actually kind of happy. Our government keeps telling people that, we're kind of happy we don't have it immediately because we actually kind of want the British to shove it in tens of thousands of people, and then we can see what happens, and then 2 weeks later we can decide whether we're going ahead. So I think that's one of the interesting things, is somebody had to be first, and people owe the British people a big vote of thanks for being guinea pigs.
I did hear that they're having a a lot more non-lethal side effects
Yeah.
from the second vaccination.
Yeah.
From the second, because this is unfortunately a two-pronged vaccine.
Like shingles.
Where you have to get a booster shot 3 weeks or so after the first shot. And apparently after the second shot, people are having like flu-like symptoms. I'm not talking lethal symptoms, but some of the lethal side effects you might not even see right away. Or you might not know that they're from the vaccine. But I'm not that worried about allergic reactions. I've never had allergic reactions to any sort of vaccine before.
Do you think anybody in your unit will quit rather than be vaccinated?
I think some people won't want it, yeah.
And if they give it this old have it or quit, what do you think they'll do? When it comes to it.
There's a few people that feel quite strongly, I don't know.
The anti-vaxxer movement's really been very insidious.
I think it just goes to show that even though we work in a world that is, I'm giving drugs to patients constantly, I'm giving medical treatments constantly, I'm giving injections, I'm putting artificial things in people's body all the time. We're not so, we're not immune,
we're not different,
dare I say, to conspiracy theories or to feeling like this is not being done right. We're not immune to the chatter on the internet about, ooh, this is terrible. We're not, even though we are the pushers of treatments. We are the pushers of things all the time. And it's funny. I think the fear factor of vaccines, the fear factor of COVID.
I'm much more frightened of COVID.
They are seen kind of equatable, and actually, I'm much more worried about getting tuberculosis, HIV, COVID, SIRS. You know, MERS. If I'm in exposure with that, I know that that's something lethal coming at me. I'm not that worried about getting vaccinated. The history of vaccines, when you think about what they used to do with smallpox and just grind up a little bit of a pustule and inject it in people.
Worked though, didn't it?
Those people were very, very brave, and it didn't always work.
No,
I mean, it worked if you survived it.
It works for the population health. Yeah. And I think that's one
of
the issues.
But it was a very unscientific way.
If you point to the one person you know in the 10,000 who becomes brain dead because of the vaccination, but in truth, 10 people die from the infection.
Took a pustule from you, and I accidentally got live vaccine instead of dead. It was such a that was a scary thing. I'm not sure I'd have been brave enough to do that. But
smallpox was pretty bad.
What we're doing now is much more controlled than that, and the side effects are usually quite statistically.
So people out there are saying there's actually nanoparticles in the vaccine so they can track and trace you forever, which makes me laugh because...
Well, they got their cell phones, for God's sake.
I mean, if we are that sophisticated, we can put nano trackers in people and make it targeted for the individuals, because if you think about it, if we've all got a tracker in it, you know the people there, we don't know who they are. I mean, all that stuff's still out there in the population. People are very sceptical. And I think they have the right to be sceptical, but at the end of the day, they have to ask themselves a question. Are the governments literally trying to kill them? And some people believe the answer is yes, and I don't know why they're online and not hiding in the woods at this point. But at the end of the day, I definitively will do my best to get vaccinated as soon as I can. I really am concerned about getting COVID. I don't want it, and I think it could be quite bad for me. Chances are it won't be. Percentage-wise, statistically, I'll be okay. But I don't know, I'm 56, I got a bit of hypertension, I'm a little fat. I don't want to get COVID.
Well, I don't want to get COVID.
I certainly don't want to have long COVID, which, as I keep telling everybody, could last the rest of your lifetime. We don't know.
Well, if there's irreversible damage to your lungs,
like
if you get
COVID,
or if you have a stroke, or those things are irreversible.
The same 22% of survivors, so if you get COVID, 1 in 5 chances you would not have the energy to do yoga ever again. Or walk a dog ever again. That's pretty significant to me.
I really don't want to.
Yeah.
I'd really rather get through this whole experience and not have COVID, definitely.
So, do you consider yourself to be a hero?
No.
Why not? People would say you're a hero, you go into COVID rooms.
What is a hero?
Yeah, true. What is a hero?
What is a hero?
Do you think people should be out there clapping for you because they don't do that anymore?
I don't think they need to be, no.
If you know a paramedic, if
training?
you know a nurse, if you know a doctor, if you know a care assistant, if you know somebody who works in a hospital as a cleaner, and you've got the means and the ability to do it, just say thank you once in a while.
You know what I do?
On an individual level.
I do think that the rescue dog people should give me a lovely dog because I'm a nurse.
So if anybody out there has a lovely dog that is pet friendly, that is happy to sleep for 12 hours every other night or so, drop us a line in the comments and we will find you.
I do think that would be nice. I would pull the nurse card for that if it would help.
You want a dove scoop. Anyway, I think that's about it, unless you've got anything else you want to say?
No.
No? So that's it for us. Feel free to subscribe to the channel. If you subscribe to the channel, you'll see more of Kitty. If you don't subscribe, you'll see more of me. Toodles.
How does that work? Why is it that way? I don't understand.
It doesn't make logical sense, but it's YouTube. You shouldn't have to make logical sense on YouTube. Right?
All right.
So if my subscriber base rises, I'm going to force you to do more videos. How, I don't know. Yeah. You're very incalcitrant doing videoing. So you guys are lucky that I got her to do this. It's took me about 5 weeks to arrange this. And I finally captured her on camera. If you have any specific questions about what Kitty does or what Kitty said or got any observations, please feel free to put them in the comments. I'm absolutely delighted most of the time to answer comments. One of the things I'm transitioning away from is the absolute junk that some people are throwing at me still about hydroxychloroquine and fake diagnosis and all that stuff. I can't stand it. Like, do you in your hospital, in your experience, have you seen COVID patients who aren't COVID patients compared to COVID patients who aren't COVID? Like, are you seeing fake COVID patients? COVID patients diagnosed with COVID but they're not?
No.
Are you seeing COVID patients that probably are COVID that never got diagnosed?
Yes.
Right. So I think there's the truth of it. Like, it's underreported compared to overreported, and I'm getting sick and tired of people telling me it's nothing.
I'm puzzled by the false positives. I have heard of some false positives.
There are a few.
Yeah. It was more, in the early days, our assumption was more that we had false negatives than false positives. I don't know. We have refined our treatments more. We do not intubate as quickly as we used to. Because we have found that it is not helpful. So people are encouraged to deep breathe, do breathing exercises.
So I think people maybe an entirely separate video on what you guys are actually doing might actually be a good idea.
Okay.
All right. Toodles.
Bye.
This is a Hungry Kitten production 2020.